High blood pressure or hypertension is defined as a chronic condition predominantly in older patients where they have a sustained blood pressure of at least 140/90. It is attributed as one of the most preventable causes of premature morbidity and mortality in the UK, with more than 1 in 4 adults with the condition. Its relationship with a range of conditions, such as coronary heart disease and stroke, contributes to an annual cost of £2 billion to the NHS. For every 10 millimeters reduction in blood pressure, there is a 17% reduced risk of coronary heart disease and a 13% reduction in all-cause mortality.
Maintenance of normal blood pressure is dependent upon the relationship between cardiac output and peripheral vascular resistance. Augmenting either cardiac parameter or both increases blood pressure. However, studies have demonstrated that increased vascular resistance and stiffness play a dominant role in the progression of adult hypertension, whilst elevated cardiac output is often considered as the precipitating factor in the younger population. So how is blood pressure regulated? There are several physiological mechanisms that govern blood pressure control, and understanding these pathways have yielded antihypertensive drugs that can be used as therapeutic agents. Circulating levels of adrenaline and noradrenaline are increased following stimulation of the sympathetic nervous system. This promotes cardiac and vascular modifications, such as increase in cardiomyocyte contractility and arteriolar constriction, following activation of various adrenergic receptors throughout tissues. This allows the body to adapt to periods of higher energy demand.
Next, we have the renin-angiotensin-aldosterone system. Renin is secreted from the juxtaglomerular apparatus of the kidney in response to underperfusion of the glomerulus or reduced circulating concentration of sodium. This endocrine pathway ultimately results in angiotensin-converting enzyme to produce angiotensin II, a potent vasoconstrictor which increases blood pressure. It also stimulates aldosterone release from the adrenal glands, which increases blood pressure further via sodium and water retention. There's also a degree of local controlled blood pressure. The endothelium generates a variety of chemical mediators, which are important determinants in vascular tone. This includes nitric oxide and endothelin, which act as a vasodilator and vasoconstrictor respectively. Hypertension can be classified as either primary, also known as essential, or secondary hypertension. Essential hypertension is the most common type in adults, accounts for approximately 90 to 95% of all cases, and has no clear single identifiable etiology. On the other hand, secondary hypertension is rarer and more prevalent in younger patients. It is due to an identifiable cause, with which the most common include renal disease, endocrine conditions such as primary aldosteronism, and obstructive sleep apnea.
There's an interplay between environmental, behavioral, dietary, and genetic risk factors that contribute to the progression from a normotensive to a hypertensive phenotype. These include factors like age, obesity, African descent, and high sodium diet. Hypertension is often described as a silent killer, as a significant percentage of the population are asymptomatic. However, if untreated hypertension persists, pathophysiological symptoms such as headaches, dizziness, and blurred vision can develop. NICE guidelines on hypertension cover the diagnosis and optimum management for patients, with the aim of reducing the risk of major cardiovascular events. Factors that guide treatment include age and ethnicity. Hypertension is also stratified into several clinical stages, depending on the blood pressure reading. The majority of patients achieve optimum blood pressure with lifestyle changes and the use of up to 3 antihypertensive drugs: ACE inhibitors, calcium channel blockers, and a thiazide-like diuretic.
But what about patients where this is not enough in lowering blood pressure? If patients have persistently high blood pressure and are already on the optimum tolerable dose of 3 antihypertensive drugs, including a thiazide diuretic, they are classified as having resistant hypertension. To learn more about this, we would like to introduce Abdullah, who is coming to visit his GP to discuss how his treatment can be escalated.
A clinical diagnosis of hypertension was made by Abdullah's GP 4 years ago. He is currently on an ACE inhibitor, a calcium channel blocker, and a thiazide-like diuretic. His clinic blood pressure in his previous appointment measured 155/94. Suspecting Abdullah has resistant hypertension, the GP offered ambulatory blood pressure monitoring, which calculates the patient's average blood pressure during their normal waking hours. He further checks if Abdullah has postural hypertension as a side effect from his polypharmacy. His results have come back as 146/88, which confirms his diagnosis, doubling his risk of a major cardiovascular event.
His GP performed further investigations to identify target organ damage and assess his cardiovascular risk. The GP will aim to review the medications, how Abdullah has been managing the lifestyle interventions, and importantly, learning if the cause behind the hypertension is poor adherence, which is commonly found amongst these patients. Patients themselves attribute the cause of hypertension to stress, diet, body weight, and alcohol. Interestingly, patients interpret periods of low stress as a sign of low blood pressure and stop taking medications accordingly. Patients are also concerned about adverse side effects such as ankle edema, increased urinary frequency, and men are concerned about impotence and gynecomastia. Causes of unintentional non-adherence are typically due to forgetting to take the medication and a busy work schedule where it's difficult to attend appointments. Abdullah says he finds it difficult to remember to take multiple medications at different times of the day. Despite optimal doses of 3 different antihypertensive drugs, the GP must now decide which antihypertensive agent will be best for Abdullah in terms of efficacy and cost effectiveness, with the goal being to reduce and maintain his clinical blood pressure to below 140/90. This will be guided by the patient's blood potassium readings. If it is 4.5 millimoles per liter or less, the anticoagulatory spironolactone is recommended at low doses. If this is not the case, alpha or beta blockers are recommended.
Previously, patients like Abdullah would have been prescribed a higher dose of their thiazide-like diuretic. However, it was later revealed that there is no improvement in cardiovascular outcome. The GP must therefore decide between spironolactone, alpha or beta blockers as the appropriate escalation of treatment. Let's explore the effects of these drugs and the mechanism of action that underpins them.
Beta blockers inhibit beta-adrenergic receptors and act as a way to influence the effect of sympathetic drive. These receptors are found in cardiomyocytes and the sinoatrial node. Their inhibition prevents a signal transduction pathway that will otherwise cause a positive inotropic and chronotropic effect. Therefore, cardiac output does not increase and blood pressure is reduced. First generation beta blockers are non-selective, but more recent second and third generation have a greater affinity to one subtype. The effect of beta blockers have been researched extensively, with a systematic review incorporating 56 studies demonstrating the significant effect beta blockers have in lowering systolic and diastolic blood pressure compared to placebo. However, common side effects of beta blockers include cold hands, the risk of bronchospasm, and sleep disturbances. Alpha blockers work in a similar fashion, but instead antagonize alpha adrenergic receptors, which mediate vasoconstriction. Alpha blockade therefore causes a reduction in total peripheral resistance and hence blood pressure. Their side effect profile include headaches, ankle edema, and lethargy.
On the other hand, spironolactone is a potassium-sparing diuretic and antagonizes aldosterone. Stimulation of aldosterone receptors in the distal convoluted tubule and collecting duct result in the synthesis and transport of sodium channels and sodium-potassium ATPases. The inhibition of spironolactone therefore reduces the reabsorption of sodium and increases diuresis. So how does this translate in practice? A trial prescribed spironolactone to patients already on other antihypertensive agents, and it was found that it caused a reduction of systolic and diastolic blood pressure of 13% and 11% respectively. However, 13% of patients experienced side effects, with 6% being men complaining of gynecomastia or breast discomfort. It further increased the risk of hyperkalemia.
So is one drug superior to another? The National Institute for Health Research funded the Pathway 2 trial, which aims to explore which drug is most effective that can be recommended for the treatment of resistant hypertension. Of the 230 patients that completed the study, in addition to taking an ACE inhibitor, a calcium channel blocker, and a thiazide or thiazide-like diuretic, the patient was given a placebo for 1 month and subsequently rotated between taking spironolactone, bisoprolol, doxazocin, or remain on placebo.
It was found that spironolactone at a dose of 25 and 50 milligrams a day was more effective at reducing home systolic blood pressure compared to placebo, bisoprolol, and doxazocin, and it had a steeper dose response compared to the other groups. Bisoprolol and doxazocin had a significant decrease in blood pressure when compared to placebo, thus being alternatives to patients who are intolerant to spironolactone. Whilst promising, there are a few limitations to the study. Whilst the effects on blood pressure have been seen, there is no information on whether the drugs directly relate to a reduced risk of morbidity and mortality. This is not very informative when considering patient outcomes. Also, each group rotated between the drug options without an interval washout period, so a carryover effect cannot be excluded.
In the run-out phase of this trial, it was suggested that amiloride could be as effective as spironolactone in lowering blood pressure, providing alternatives to spironolactone treatment. However, informed clinical decision-making requires consideration of a variety of factors. This includes drug cost, resource availability, and patient compliance. Amiloride is more expensive and taken twice a day, whereas spironolactone is taken only once a day and less expensive. Hence, spironolactone treatment is a more convenient option for people like Abdullah who are already taking multiple medications. Several other trials show that whilst beta blockers lower blood pressure, they are actually inferior at reducing cardiovascular events such as stroke compared to other antihypertensive agents, including ACE inhibitors and calcium channel blockers. Patients on beta blockers furthermore had a higher risk of type 2 diabetes. Finally, the risk of all-cause mortality was no different when beta blockers was compared to placebo. This resulted in their use as a first-line treatment to be downgraded to a fourth-line treatment status by NICE. From an evidence-based approach in context of the patient, spironolactone's superior ability in lowering blood pressure compared to beta blockers makes it the most appropriate treatment.
Spironolactone's use as an antihypertensive is currently unlicensed but would still be appropriate. The GMC stipulates that prescription of unlicensed drugs is acceptable in cases where there is no suitable licensed medication to meet the patient's need. The GP commences low-dose spironolactone for Abdullah and has booked a blood test in a month's time to check his renal function and potassium levels. The benefits of commencing spironolactone need to be balanced and discussed with its side effect profile of impotence and gynecomastia. Whilst the GP has solved what to prescribe using an evidence-based approach, other exciting treatments are emerging for resistant hypertension. These include renal nerve ablation, which aims to disrupt neurogenic reflexes involving blood pressure control, as well as baroreceptor stimulation, which involves electrically stimulating the carotid baroreflex, which controls blood pressure by regulating autonomic nervous activity. Trials have shown significant decreases in blood pressure for both treatments, but more needs to be done to evaluate long-term efficacy and safety.
Whilst the risk of a major cardiovascular event doubles in patients with resistant hypertension, there is very little evidence on the treatment of these patients. The addition of low-dose spironolactone has been shown to be preferential at lowering blood pressure, but there's a need for more research on whether this translates to a reduced risk of morbidity and mortality in this population. Until then, clinical decision-making is based on experience, evidence-based medicine, and empowering the patient to be at the forefront of their care.